Yes, ma'am.
So I welcome one and all on behalf of Oxy for the Oxy and Foxy's Journal Club. And this will be a webinar. We have been doing it every second Tuesday. So this month, this theme is medical disorders in pregnancy. So we have beautiful cases which has been presented today. So one is about heart disease, another one is renal disorders, and definitely the much wanted, awaited Gestosis score as well. And so with this, I would like to start off with the webinar, and I thank for all the Foxy office bearers as well. So I would like to, yes, next slide, please. Yes. So I would like to introduce my co-chair and the co-host as well for today. She has a connectivity issue, but she'll be joining. So Dr. Deepa Tangamani. So she is a consultant, Apollo First Med Hospitals and Thamare Fertility Solutions. And she's been the joint secretary, ATN RCOG, advisory committee member of Oxy, and now she's an executive committee member. And she has been the chairperson of Oxy for clinical research and quiz committee. So the next slide, please. So along with her, I will be your co-host. So we will start our program with lighting of the Kuttuvilakku. I would welcome all the delegates to please join us for the enlightening of the Kuttuvilakku. Thank you. So it is my privilege to welcome Dr. Vijaya Madam. She is our very dynamic president for this year 2024 Oxy, a former director of IOGM MMC, and she's been the Foxy Medical Education Committee member with special interest in high-risk pregnancy, infertility, laparoscopic surgery. So Madam will be joining us shortly. Can we have the next CV, please? So Dr. Geeta Lakshmi Madam is our secretary of the Oxy 2024. Madam has been UG/PG teacher for the past 22 years. Now she is a professor in the RSRM, Government RSRM Stanley Medical College, and she's been member of various societies, presented papers in national and international conference with again special interest in high-risk obstetrics, adolescent program, and medical education. Next, please. So I would like to give the Oxy prayer because our secretary is held up with an emergency. So thank you, God. In humility we gather. In gratitude we pay for all the good things you have given us. Shiver us with your blessings to pass on to the healing touch, to celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you. So it is my privilege to welcome Dr. Surekha Tyagade Madam. Madam is the chairperson, Foxy Clinical Research Committee. She has been in the West Zone Coordinator for Practical Obstetric Committee of Foxy and a member of the Medical Education Committee and IMA. She's been the chairperson for the Global Women Health Task, and she's had so many publications with projects and been chapters in books, as well as been a reviewer in many journals. We all know that she's very well knowledge. She'll be joining us shortly. Can we have the next slide, please? So it is my real privilege to welcome Dr. Papa Desari Madam. Madam is a past professor of Obs and Gyn in Jipmer Medical College, and now she is in SVM CHRC Puducherry. She's been the Dean of Research and the PG Academics. Madam has been the HOD Jipmer, and she'd been a Secretary of Obs and Gyn Society of Puducherry in 2004 to 2009, has been a president from 2019 to 2021, founder secretary of IFS Puducherry, founder president of Puducherry Menopause Society, president JIPMER Scientific Committee 2019-20, accomplishment as a CS Dawn Award in 1994, Udiland Award New Zealand in 2004, Best Paper Award in the Indian Journal 2005, Best Paper Presentation ASC OG, and she has had so many presentations and so many awards, including the BIST Award and the Nair Award. And Madam has 205 publications and 6 chapters in books with, like established IVF services in JIPMER. And we all know Madam is like, her knowledge is very vast and she's here to share with us her knowledge on research. Welcome to you, Madam. So our next guest, we all know Dr. Premlata, Madam. She doesn't have any, introduction at all. She's a consultant head of the Department of Obs and Gyne in Dr. Mehta Mehta Hospital. She's a retired director of IOG Chennai, and she's a past president Oxy 2022. Now she's the vice president Chennai Menopause Society, a life member of IH and ISOPAP, expertise in tubal microsurgery, special areas in infertility and laparoscopy, authored a book, and also had a Lifetime Achievement Award. Welcome to you, Madam.
Thank you.
So it is my privilege to invite Dr. Sunita Samal. She's a consultant Obs and Gyne, Apollo Women's Hospital. She's a former HOD of SRM Medical College, former professor of MGMC, UG/PG teacher for 16 years, a DNB faculty, special areas in laparohysteroscopies, vaginal surgeries, high-risk obstetrics, basic infertility. I think everything in Obs and Gyne, she'll be there. She has 52 various national and international journal publications, awarded best paper in very many years of Oxy-Foxy conferences. And she has been with us in Oxy programs for very many years. She has been the judge for many of our paper poster presentation. So think of research, we will always have Dr. Sunita in mind. So welcome to you, Dr. Sunita.
Thank you, Priya.
Thank you, ma'am. Thank you. So the first session, it will be Dr. Abhirami Prashant. She's a junior resident with Dr. Mehta's Hospital. She'll be presenting on the pregnancy outcome in women with kidney transplant, a meta-analysis and systemic review. So before we start our program, I would like to invite Dr. Edwin Fernandez. Sorry, we don't have your CV, sir. Sir is the head of the Department of Nephrology of Mehta Hospital, and also the professor of nephrology in Stanley Medical College. So welcome to you, sir. Thank you for joining for the nephrology session.
Thank you. Thank you. Thank you, Priya. Thank you, everyone, for the invitation.
So, Dr. Abhirami, you are there. You can share your slides. Can you share your screen, please? Yes, we can see your screen. Can you switch on your video so that we like to see you as well?
Yes, madam.
Thank you. I think there is some issues with your video. You cannot do it, it's fine.
Madam, is it...
Sorry, I cannot see you. Yes, I can see you. Yes,
okay,
I can see you. Yes. Start. Over to you,
Yes, madam. Yes, madam. Good evening to all respected madams and sir. Today my topic is pregnancy outcomes in women with kidney transplant, a meta-analysis and systematic review. Reproductive function in women with end-stage renal disease generally improves after kidney transplant. However, pregnancy remains challenging due to the risk of adverse clinical outcomes. The primary goal of this study was to perform a meta-analysis to systematically identify all studies of pregnancy-related outcomes in kidney transplant recipients from all around the world and estimate pooled incidences of pregnancy outcomes, maternal complications, and fetal complications. The secondary goals were to examine the impact of pregnancy on the kidney allograft loss, allograft rejection, identify ideal maternal age of conception, and to determine ideal time of conception between kidney transplant and pregnancy. Women with end-stage renal disease, they have impaired fertility due to disruption of hypothalamic gonadal axis. Pregnancy is therefore rare in women on dialysis with very low incidence of conception ranging from 0.9 to 7%. Since there is rapid restoration of fertility in some cases within 6 months following the transplantation, kidney transplantation offers the best hope to women with end-stage renal disease who wish to become pregnant. Pregnancy in a kidney transplant recipient continues to remain challenging due to the risk of adverse maternal complications of preeclampsia, hypertension, risk of side effects from immunosuppressive medication, risk of deterioration of allograft function. The risk of adverse fetal outcomes like premature birth, low birth weight, small for gestational age infants is also high. The comprehensive analysis of various worldwide registries, single-center studies, case series will provide generalizable inferences about post-kidney transplant pregnancy outcomes and help guide the pregnancy in the kidney transplant recipients. So our study comprises a systematic review and meta-analysis reported according to the PRISMA guidelines for studies exploring incidence and outcomes of pregnancy in women with kidney transplant. So these are the references from where the data was collected. They were PubMed, Elsevier, Embase, Scopus, Biosis Previews, ISI Science Citation Index Expanded, Cochrane Central Register of Controlled Trials, American Transplant Congress's Abstract. These studies include from the date of inception through August 2017 for studies reporting pregnancy with kidney transplant. So here is again a table which is showing the selection of studies reporting outcomes of pregnancy in women with kidney transplant. So next is the selection criteria in our study. This includes observational studies, that is prospective cohort, retrospective cohort, cross-sectional studies, case series and case reports with a number of pregnancies more than 10 that explored the pregnancy maternal fetal outcomes among women more than or equal to 18 years and who received a kidney transplant. The exclusion criteria, it was the studies of patients with multiple organ transplants, studies that analyzed the teratogenic effects of mycophenolate or sirolimus, and non-English language studies were excluded. So the data extraction was carried out independently by 3 data extraction team members using standard data extraction forms. The data elements were then rechecked for accuracy by all the 3 data extraction team members. When more than one publication of a similar patient population existed with more than 25% of overlap, publication with higher number of pregnancy events and the most complete details was included. So these are the parameters which was included in our data extraction. They were country of location, years of data collection, number of kidney transplant recipients, number of pregnancies, the mean maternal age, mean interval between kidney transplant and pregnancy, pregnancy outcomes, that is number of live births, miscarriage, induced abortion, stillbirth, ectopic pregnancies. Maternal outcomes, which includes number of women with preeclampsia, pregnancy-induced hypertension, GDM, number of cesarean sections. Fetal outcomes, which includes number of preterm births, mean gestation age, mean gestational weight, and number of neonatal deaths. The graft outcomes, it includes number of acute rejection during pregnancy, graft failure post-pregnancy, and mean serum creatinine pre and post-pregnancy. So this is about data synthesis and analysis. The pregnancy incidence was reported for women per 1,000 live births. Patient characteristics were reported as frequencies. And for each study, the estimates were expressed as prevalence and 95% confidence intervals. 2 sample test of proportions was used to compare the pooled incidence for each analysis in the most recent United States general population incidence. This determined the associations of maternal age, the interval between kidney transplant, and the pregnancy outcomes. So additionally, a subgroup analysis was also performed for the pregnancy, maternal, and fetal outcomes for studies published from 2000 to 2017. So here we can find the studies which was included in the meta-analysis. So comprising the all other studies from 87 countries. So among the 134 citations that were retrieved, 136 full-text articles were reviewed and 87 were selected to be included in the final study cohort. So 3 studies were from Africa, 31 from Asia, 31 from Europe, 10 from North America, 4 from Oceania, and 8 from South America. Overall, there were 6,712 pregnancies in 4,174 kidney transplant recipients. So the mean maternal age was 29.6 plus or minus 2.4 years, and mean interval between kidney transplant and pregnancy was 3.7 years. So these are the results in our study. The pregnancy outcomes were the live birth rate was 72.9%, miscarriage rate was 15.4%, induced abortions rate were 12.4%, stillbirth rate were 5.1%, and rate of ectopic pregnancy were 2.4%. So the results from our study group, it was compared with the US general population. So here we can see the live birth rate has increased in our study group, that is 72.9% compared with 62% in the comparison group. And the miscarriage rate and then the induced abortion rates, they have a fall. That is, for miscarriage rate, we have 15.4% and induced abortion rate was 12.4%. Stillbirth rate, it again had an increased rate, that is 5.1% comparatively to the comparison group. And rate of ectopic pregnancy has also been increased in our study group, that is 2.4%. So next is the maternal outcomes and kidney transplant recipients. So the rate of preeclampsia was 21.5%, and the cesarean section rate was 62.6%, and the rate of gestational diabetes mellitus was 5.7%, and pregnancy-induced hypertension was 24.1%. So the preeclampsia rates, it was the highest in Oceania, that is 27%, followed by North America, it is 25.5%. It was lowest in Africa, that is 10.5%. So C-section rate, it was highest in South America, that is 88.85%, followed by Africa. Pregnancy-induced hypertension, it has the highest rate. It was reported in South America, that is 48%, while the lowest rate was reported in Africa, that is 16.1%. So next, coming to fetal outcomes, the preterm birth rate was 43.1%, and the neonatal mortality rate was 3.8%, and the mean gestational age was 34.9 weeks, and the mean birth weight was 2,470 grams. Neonatal mortality was high across all geographical regions as compared to US general population mean, that is 3.8% versus 0.4%, with highest rate in Africa and lowest rate in North America. So coming to the graft outcomes, the overall acute rejection rate during pregnancy among 822 kidney transplant recipient was 9.4%. Among 489 recipients in 12 studies where 2-year post-pregnancy graft loss was reported, there were 32 cases of graft loss, that is 9.2%. So here we could find the pregnancy-related outcomes stratified by study mean interval between the transplant and pregnancy. Here, when the time of interval between the kidney transplant and the pregnancy was 2 to 3 years, the induced abortion rates and the neonatal deaths and rates were higher, that is 16.1%, and neonatal death was 9.3%. The maternal outcomes like preeclampsia, it was also higher when the year is more than 3 years, and it is lower when it is less than 2 years. And the live birth rate also, it was higher when the time between the kidney transplant and pregnancy is more than 3 years, that is 75.4%. And then it is less favorable, that is 68.3% when it is between 2 to 3 years. So next is pregnancy-related outcomes stratified by study mean metal age. The spontaneous abortion rates were higher when the metal age is less than 25 years, that is 19.8%. And also it is increased when the metal age is more than or equal to 35 years, that is 18.2%. And metal outcomes like preeclampsia, it was also increased when the metal age is more than or equal to 35 years, that is 27.3%. So coming to discussion, the results of our meta-analysis show that although majority of pregnancies in women after kidney transplant result in live birth, both maternal and fetal adverse events are common. Rates of preeclampsia, stillbirth, and cesarean section were significantly higher than in the general population. Also, complications like preterm delivery, first or second trimester loss, stillbirth, and neonatal mortality were higher. The live birth rates in women after kidney transplant were higher than in the general population. That is 73% in kidney transplant recipients compared to the general population, that is 62%. So this higher live birth rate, although appears encouraging, it may reflect a reporting bias or selection bias in which relatively healthy women decided to pursue pregnancy and they received better medical support. It is also important to consider that there are inconsistencies in definition of live birth rate used in various studies. For example, in some studies, the live birth rate was defined as per 1,000 female transplant recipients, whereas in some studies, it was defined as per 1,000 pregnancies in transplant recipients. So in general population, this live birth rate is defined as per 1,000 population according to Centers for Disease Control. A meta-analysis examined pregnancy outcomes of 4,706 pregnancies in women with kidney transplant and reported a live birth rate of 73.5% according to Deshpande. So Davison, he estimated that just under 40% of conception, they do not undergo beyond the first trimester, but of those that do, greater than 90% end successfully. And our study highlights the significantly higher risk of maternal and fetal complications in women with kidney transplants. About a quarter of women develop preeclampsia, almost 6 times higher as compared to the general US population. In an international multi-center retrospective cohort of 52 women who underwent kidney transplantation reported preeclampsia rate as high as 38% and chronic hypertension rate of 27%. So rates of stillbirth and neonatal mortality were significantly higher in our study as compared to the general population because of risk factors like prematurity, preeclampsia, presence of other risk factors like hypertension, proteinuria, and serum creatinine levels of 1.5 mg per deciliter or higher. In our study, the rates of cesarean section was also higher than 2-fold as compared to the general population. A study also reported that more than 3/4 of the deliveries in the kidney transplant recipients were by the cesarean section, but only 3% were performed for the indication of renal transplant, according to Braham. So the ideal time of conception in women with renal transplant is between 1 and 2 years after transplantation, according to guidelines by American Society of Transplantation. However, the European best practice guidelines recommend delaying pregnancy for a period of 2 years after transplantation. So live birth rate was lowest and neonatal deaths were highest in the 2 to 3 year interval following the kidney transplant in our study. Maternal complications, preeclampsia, cesarean section rates were higher in the 2 to 3 year interval and more than 3 year interval. However, in contrast, according to Deshpande, reported both the highest maternal complications and the least favorable delivery outcome of preterm births in less than 2 year interval as compared to more than 2 year interval between kidney transplant and pregnancy. Overall, fetal outcomes in less than 2 year interval seem most favorable in our study. So strength and benefits of such study, it involves a large number of pregnant renal transplant recipients from all around the globe, thus providing us with information about pregnancy outcomes for the heterogeneous population. Additionally, we have analyzed region-specific outcomes and identified outcomes which may require intensive management pertaining to that region. This will help in making future region-specific guidelines for follow-up and management of pregnancy in kidney transplant recipients. So this meta-analysis of pregnancy outcome in 6,712 pregnancies in 4,174 kidney transplant recipients with the data spread over different decades from all over the world shows favorable outcomes with the live birth rates exceeding that in the recent national population. However, pregnancy after a renal transplant confers significant risk in terms of maternal and fetal adverse events, including increased rates of preeclampsia, gestational diabetes, cesarean section rates, and pregnancy-induced hypertension. The risk of prematurity and low birth rate is also high. So the definitions used in evaluating these outcomes, that is the live birth rates, also need to be standardized. The results of this study can help the healthcare providers with appropriate counseling and individualized management of this high-risk population. Thank you.
Thank you, Dr. Abhirami. Actually, you have congratulations. You have gone through the meta-analysis very nicely.
Thank you, madam.
What I was intriguing in that you have added in the study says about induced abortion rate, but we don't know whether induced abortion rate of 12 point, is that rate? It comes to 12.4%, whether it is because of the medical grounds or the patient socially, they didn't want to have a pregnancy. And that has been included in the pregnancy outcome. That was a thing, but it has not been, has it been detailed in the study?
No, madam. No sufficient data is available, madam, about the induced abortion rates, madam.
Other thing, live birth rate, as you told earlier, as you told clearly, the live birth rate as per the CDC in US population, they are told about 1 in 1,000 population.
Yes, madam.
Yes, about 1 in 1,000 pregnancies. That is why there is a discrepancy compared to general population here. Another factor which is intriguing in this study is the live birth rate does not include we have exclusion criteria is the pregnancy which were because of the immunosuppressant effect and teratogenicity that has been excluded. If that had been included, the total live birth rate per 1,000 pregnancy may be actually less. That's what I'm thinking. It has been excluded from the study. Apart from that, I don't think any other thing we can add that thing. And what is the reason for increased cesarean section rate in this study? What is it?
Madam, because of maternal complications, madam, like preeclampsia and pregnancy-induced hypertension, madam. So we have to intervene.
Because of the maternal and fetal complication, not because of renal transplant per se. They say only 3% were the reason.
3%, yes, madam.
Thank you, Dr. Abhirami. You have gone nicely through that.
Thank you.
Next expert, Dr. Papa Tesli will be going.
Sir can tell. Nephrologist. Let sir also comment.
Dr. Edwin sir, you can tell.
Yeah, very, very nice presentation, Dr. Apurva. The outcomes of pregnancy after transplant differ in different situations. In a country like ours, we are a little better than Africa, I suppose. So in the large population that we see at the government hospitals, both at Madras Medical College and Stanley Medical College, the most important thing is counseling. So when there's somebody who's had a transplant in the childbearing age group, after transplant, we have to advise them contraception. So the contraception cannot be OCPs because these OCPs can have drug interactions with the drugs used for immunosuppression. So either we advise them a barrier method, or if they have given birth to a child already, some progesterone-eluting devices. These are better, and we strictly counsel the husband and the wife regarding postponing the pregnancy. Ideally, I would say at least 2 years, though the literature says 1 year, 2 years would be ideal. At the end of 2 years, I would look at this patient and say whether the creatinine is stable, not had any acute rejections, drug levels are fairly well, and hypertension is under good control, because most of our patients continue to have blood pressure even after transplant. So somebody on one drug and blood pressure is well maintained, I would say, and not much of proteinuria, creatinine of less than 1.5, I would say okay. The most important thing here is once I decide that she is fit for a pregnancy, the mycophenolate mofetil, the drug that is a very important drug that we use, has to be stopped because this is teratogenic. It's embryopathic rather. So we tell them to stop mycophenolate at least 9 weeks prior to the planned date of conception. And then we have to substitute this with azathioprine, because once you're withdrawing a particular drug, then we'll have to substitute an alternate equally efficient immunosuppressive drug. The other two drugs, tacrolimus and steroids, they are not teratogenic and they can be continued during pregnancy. So mycophenolate is the drug that we are particularly looking at. We stop mycophenolate, put them on azathioprine, and then look whether the graft function is stable before we allow them to get pregnant. Accidentally, somebody may get pregnant. In spite of our counseling, somebody on mycophenolate may land up with pregnancy, and then it becomes a big problem for us because we know very well that this is an embryopathic drug. So we sometimes stop it there, and then we tell the patient that all this has been, these fetal abnormalities have been described in the literature. Would you still like to go ahead with the pregnancy, or would you offer an MTP to them to see whether we could prevent these malformations from happening, because these malformations can't be picked up early on a scan, etc. So then we leave it to the patient's choice. And this patient needs to be, once he gets pregnant, has to be monitored on a regular basis by a multidisciplinary team consisting of an obstetrician, nephrologist, and a pediatrician. Of course, the risk factors, they are at high risk for preeclampsia. So this has to be very, very closely followed, and it is not necessary to go for a LSCS. If we can manage by a normal vaginal delivery, that is also quite fine. And of course, the delivery has to be institutional and planned. So these are the things. We recently we are writing up a paper from all over the country, because we don't have very large numbers in India. So from all over the country, we are just gathering information, writing up a paper on this. At least personally, in our hospital, we have had a nurse who's had actually given birth to 2 children after transplant and doing extremely well, maintaining good graft function. The drug levels of tacrolimus have to be monitored during pregnancy, because these levels can go a little haywire, and then we'll have to adjust the doses accordingly. So these are the points about pregnancy and kidney transplant. It is very much possible to have a successful transplant after pregnancy. It requires a lot of counseling, a very close monitoring, and of course the patients and the families' cooperation. Over to you, ma'am. Any other experience from others?
Thank you, Dr. Edwin. Dr. Papa Dasrik, you can tell your...
Yes, so not great experience as you must have had as a nephrologist, because you deal these patients more often than us. They get pregnant and then come to us. But I want to congratulate Dr. Apurva. It is just a very wonderful presentation. Abhirami. Abhirami, sorry. Because in such a short time, she could, brief the whole article in a very efficient way. Congratulations.
Thank you,
and in Asia, what was the, I just couldn't capture, when compared to US population, in Asia, what were the number of studies, number of participants that were involved in this study in Asia? Because it was compared with the US general population, no, the outcomes.
Yes, ma'am.
So we should compare with our Asian population, and also the reasons for indications for kidney transplant. What is the background pathology? I think that when Sir is telling, I felt that when we conduct a study in a nationwide, we should take into consideration. What was the indication exactly, the pathology for renal transplant? And of course, the one other thing we can think, the outcomes are live birth rates were better than US general population. Maybe because of this multidisciplinary care and also the prophylaxis. Even with the prophylaxis, we give ecosprin, all that. Even then, preeclampsia and hypertension is very great with renal disease. And I was surprised to see that intrauterine growth restriction was not so common. And the mean birth rate is 2.4. So it's very nice presentation.
Thank you, ma'am.
Actually, in Asia, they have put 30 studies. Asia and Europe, they have more studies.
Yes, ma'am. 30 studies from Asia.
Studies from Asia.
Again, Asia is a very heterogeneous population.
Yes.
So Bangladesh may be different. They may be worse than us.
Yes.
And we may be worse than. There are countries like Thailand which have got very good nephrology setups where their outcomes are a little better. So it's a very heterogeneous population. Pakistan may definitely be worse than us. So you can't interpret Asia as a whole. US, of course, their systems are entirely different.
So you're doing for India, sir? Great.
Yeah, that is what we are doing.
Yes.
Almost every center has got about 5 to 10 patients. So we are writing up the entire thing. May take some time,
Maybe
but when it is out, I'll definitely share with your team.
Background pathology for renal transplant. We should assess that outcome.
Most of the times we are not able to find out an etiology because most of them come with small kidneys and we are unable to biopsy. The ones that do come to us early, we are able to do a biopsy. Of course, SLE is a very important cause of end-stage kidney disease in this particular age group. So lupus nephritis is one and IgA nephropathy is one. Some patients following an obstetric acute kidney injury may land up with cortical necrosis and they may get transplanted. So that is a small population of patients who actually very catastrophically have a abruptio and then develop cortical necrosis. What begins as an acute kidney injury becomes CKD and then they get transplanted for that.
I've had experience of managing these CKD patients, like as you said, abruption and intrauterine growth restriction is very, very common.
Right.
Actually, the study does not include about FGR. That is a fact. Maybe it would have been there, but the study does not.
This is after transplant, no, ma'am. So with the disease, it is less because of this management. Maybe we can believe that the mean birth rate was 2.4. Expert management.
Actually, after transplant, the risk factors are also more. Most of them are hypertensive. Post-transplant diabetes happens commonly in this age group. So it's a high-risk pregnancy. So here the risk is not only hypertension, diabetes, but the extra organ inside. So it's a very high risk pregnancy.
Thank you, sir. You've given
Thank
us
you,
a
ma'am.
lot of
Nice.
inputs.
The other challenge that we have is CKD patients who get pregnant.
Yes, yes.
It becomes a big problem because a lot of times the CKD is not picked up before marriage. And I always tell that the best stress test for the kidney is pregnancy.
Yes.
Many kidney occult and subtle kidney diseases manifest during pregnancy. So it leads to a lot of problems in the family. And then, somebody accuses the girl's parents of not revealing the disease. And then they get pregnant, they land up with hypertension in the first trimester itself, then we ask for an MTP.
Yes,
And,
yes. That's what I had,
so
these issues.
that is a bigger challenge actually.
Yes,
The
yes.
CKD
Whether to
patients getting
continue the
pregnant.
pregnancy or,
Exactly. We'll have
terminate.
to keep a very close. But if somebody develops hypertension in the first trimester, I don't think it's worthwhile. They'll end up with an IUGR and a small for dead baby. So thank you, ma'am. It was nice interacting with all of you. Thank you for
Thank you,
the
sir. Thank you.
Thank you.
So it is very nice that we are doing a study. So we are just eagerly waiting to know the outcome. Definitely. Thank you, sir. So it was like, a lot of information.
Thank you, madam.
Thank you. It was a lot of information from the session, and thank you, Dr. Abhirami. You really did a good job. So the next we will call upon Dr. Apurva, the junior resident from Mehta's Hospital. So she will be presenting to us on the outcome of pregnancy in women with bioprosthetic heart valves with or without valve dysfunction. So over to you, Dr. Apurva. So I'm sorry, I'm not going to read the introduction for my postgraduate. So we know that, and I'm very proud that both of my postgraduates are presenting today. So over to you, Apurva. Welcome, Dr. Deepa, madam. We can see you. Apurva, can you
share your screen?
Yes, ma'am.
I'm not seeing your screen yet. எனக்கு பழங்கள் பிடிக்கும் சொன்னேன் எழுத மாட்டேங்கிறேன் முட்டை பிடிக்கும்
Apurva ma'am, please share the screen, ma'am.
Yes, ma'am. Ma'am, is my screen visible, ma'am?
Yes, ma'am.
Good evening to everyone. So I'm going to present a few slides on the study conducted by Barbara Wishart-Smith on the outcomes of pregnancy in women with bioprosthetic heart valve with or without valve dysfunction, which was published in Journal of American College of Cardiology in November 2022. This study includes 125 pregnancies and the outcome of the pregnancy in women with pre-existing heart disease enrolled in a subset of the multi-center prospective carpet study, which was done between 1994 and 2019, who had undergone implantation of bioprosthetic valve prior to pregnancy and whose obstetrical and cardiac care was provided at two large tertiary care hospitals in Toronto and Vancouver were examined. And the women were followed until 6 months postpartum. Women with miscarriages at less than 20 weeks gestation or termination of pregnancy were excluded from the study. This is the first study to focus on structural valve dysfunction, that is SVD, in young women with bioprosthetic valve and its impact on pregnancy outcomes. So background, although pregnancy outcomes in women with normally functioning bioprosthetic valves are often good, structural valve dysfunction may adversely affect the pregnancy outcome, but this has not been studied. The aim of this study was to examine outcomes in pregnant women with bioprosthetic valve and the association with structural valve dysfunction. The pregnancy outcomes in women with bioprosthetic valves were prospectively collected. Adverse maternal cardiac events included cardiac death or arrest, sustained arrhythmia, heart failure, thromboembolism, and stroke. And adverse fetal events were also studied. Determinants of adverse events were examined using logistic regression. This is a slide summarizing the advantage and the limitation of the bioprosthetic valve and the mechanical valve. Bioprosthetic valve has the advantage that it is associated with low rates of complication because it does not require anticoagulant therapy, and mechanical valve has the advantage of better longevity. The limitation of bioprosthetic valve is that it is associated with structural valve deterioration, which limits the lifespan of bioprosthetic valve and necessitates reoperation. Whereas mechanical valve, it is associated with the need for anticoagulation and the risk for valve thrombosis during pregnancy. The baseline characteristics were recorded at the first antenatal visit. Some of the baseline data which was recorded was the maternal age and the years since the valve implantation, whether she was a nulliparity or multiparous, twin pregnancy, late pregnancy assessment, that is the first visit beyond 20 weeks of gestation, prior cardiac events which included arrhythmia or stroke, transient ischemic attack, or that were also included, and any comorbidities like diabetes, hypertension, history of smoking, BMI greater than or equal to 30 kg per meter square, and NYHA class 3 or class 4. Then the baseline transthoracic echocardiogram was obtained. The left ventricular systolic function less than 55% was considered abnormal, and right ventricular function was determined by visual assessment. Valvular area gradients and regurgitation was noted, and moderate to severe stenosis or regurgitation was considered significant. Now, bioprosthetic valve dysfunction was determined by 2D echocardiography and Doppler. The morphological features which were included was the presence of thickening and or calcifications of the leaflets with the restriction of the leaflet mobility. And the Doppler parameters which were included was the increased transprosthetic peak and mean gradients and a reduced calculated effective orifice area, especially in the aortic and the mitral bioprosthetic valve, and the presence of moderate to severe intravalvular prosthetic valve regurgitation. So this is how the bioprosthetic valve dysfunction was evaluated. They have also defined the stenosis and regurgitation for stenosis in each valve. In case of aortic prosthetic stenosis and mitral prosthetic stenosis, it was defined by the effective orifice area. Aortic prosthetic stenosis were defined if the effective orifice area was less than 0.8 centimeter square, and in case of mitral valve, if the effective orifice area is less than 1 centimeter square, it was defined as mitral prosthetic stenosis. In case of pulmonary and tricuspid valve, it was defined by the mean gradient and the peak velocity. These are characteristics of the bioprosthetic valve dysfunction among the study group. In this case, among the 125 pregnancies, 34 pregnancies occurred in women with left-sided bioprosthetic valves, among whom 25 pregnancies had aortic bioprosthetic valve, in which 17 were only aortic and 8 were both aortic and mitral valve. And mitral bioprosthetic valve was seen in case of 17 pregnancies had mitral bioprosthetic valve, in which 9 had only mitral bioprosthetic valve and 8 had both aortic and mitral bioprosthetic valve. Then right-sided bioprosthetic valves were seen in 91 pregnancies, in which 86 pregnancies had pulmonary valves and 5 had tricuspid valves. In 27% of pregnancies, that is 34 out of 125 pregnancies, structural valve dysfunction of the bioprosthetic valve was present. Women with left-sided bioprosthetic valve were more likely to have the structural valve dysfunction than those with the right-sided bioprosthetic valve. That is 44% in the left-sided bioprosthetic valve as compared to 21% in the right-sided bioprosthetic valve. Then the adverse maternal, fetal, and obstetric events were recorded from the first antenatal visit up to 6 months after delivery. Some of the adverse cardiac events which were recorded were cardiac death, cardiac congestive heart failure, and arrhythmia. And adverse fetal events recorded were fetal or neonatal death, preterm delivery, small for gestational age, and respiratory distress syndrome. And obstetrical events which were recorded were preeclampsia and postpartum hemorrhage. This is the slide summarizing the adverse maternal cardiac events. Adverse maternal cardiac event like arrhythmia, it complicated around 6 pregnancies, supraventricular tachycardia in 5 pregnancies, congestive heart failure in 11 pregnancies, and valve surgery was done in 3 women, in which 2 were done antenatally and 1 was postnatally. One woman with severe mitral valve stenosis presented at 18 weeks of gestation age with biventricular heart failure and underwent valve replacement within 1 week after presentation. Another woman, she presented at 19 weeks of gestation with severe aortic bioprosthetic valve stenosis and NYHA class 3 symptoms, which was unresponsive to therapy. She underwent valve replacement surgery at 23 weeks of gestation. And another woman in the postpartum period with severe mitral bioprosthetic valve regurgitation and mildly reduced left ventricular systolic function developed pulmonary edema in the early postpartum period and underwent valve replacement. Cardiac deaths were seen in one woman with severe stenosis of the aortic bioprosthetic valve and ventricular dysfunction, died suddenly at home in the postpartum period. The adverse obstetric events includes preeclampsia, complicating 1 pregnancy, and postpartum hemorrhage, complicating 5 pregnancies. And adverse fetal events include fetal death, which is complicating 2 pregnancies. And these 2 pregnancies were those pregnancies which underwent valve surgery in the antenatal period. Preterm birth, complicating 15 pregnancies, they had preterm birth, and small for gestational age seen in 19 pregnancies, and respiratory distress syndrome seen in 2 pregnancies. So, determinants of adverse cardiac events. Determinants of dysfunction of any left-sided prosthetic valve, maternal age greater than 35 years, and any previous episode of cardiac event. These were the 3 factors which were related to the cardiac events. 75% of the patients who experienced cardiac events during pregnancy had previous episodes of either arrhythmia or heart failure prior to the pregnancy. Adverse fetal events. So, adverse fetal event, the fetal event rate differed between women with left-sided bioprosthetic valve with or without structural valve dysfunction. Results. Overall, 125 pregnancies in women with bioprosthetic valve were included, out of which 27% were left-sided bioprosthetic valve and 73% had right-sided bioprosthetic valve. And structural valve dysfunction was present in 27% of the pregnancies, in which 44% was contributed by the left-sided bioprosthetic valve and 21% was contributed by the right-sided bioprosthetic valve. So, women with left-sided bioprosthetic valve were more likely to have structural valvular dysfunction than those with the right-sided bioprosthetic valve. Cardiac events occurred in 13% of the pregnancies and were more frequent in women with structural valve dysfunction compared with those with normally functioning bioprosthetic valve. Cardiac events were more common in left-sided bioprosthetic valve with structural valve dysfunction as compared to the normally functioning bioprosthetic valve. But no significant increase in cardiac events in right-sided bioprosthetic valve with SVD and without SVD was seen. Of the 8 women with left-sided bioprosthetic valve who had cardiac events, 63% had severe bioprosthetic valve stenosis and 25% had moderate or severe bioprosthetic valve regurgitation. So, the cardiac event rate was higher in women with left-sided compared with right-sided. That is 24% versus the 9% in the right-sided. And this increased risk with left-sided bioprosthetic valve was driven by the high rates in women with SVD. Fetal event rate was also particularly high in women with left-sided bioprosthetic valve with SVD, that is structural valve dysfunction. Discussion. In this cohort study from 2 Canadian tertiary centers, more than 1/4 of all the pregnant women with bioprosthetic valve had structural valve dysfunction, although time since valve replacement surgery was on an average 6 plus or minus 3 years. In this study, structural valve dysfunction was identified in 27% of pregnancies at first antenatal visit. Structural valve dysfunction was more than twice as common in women with left-sided bioprosthetic valve compared with those in the women with right-sided bioprosthetic valve. And durability of bioprosthetic valve is reduced in young patients in whom structural valve dysfunction may be accelerated because of higher functional demand and a more active immune system. Another important difference is in the rates of structural valve dysfunction between women with left and right-sided. So, bioprosthetic valve at the time of pregnancy, 44% of the women with left-sided bioprosthetic valve had structural valve dysfunction on an average in 7 plus or minus 3 years after surgery, and 21% women had right-sided bioprosthetic valve had structural valve dysfunction on an average of 11 plus or minus 7 years after surgery. So, structural valve dysfunction, we have seen that the durability of bioprosthetic valve is reduced in young patients in whom the SPD may be accelerated because of higher functional demand and a more active immune system. And earlier degeneration of the left-sided BPV is due to higher functional demand in a high-pressure circulation as compared to the low-pressure circulation in the right side. So adverse cardiac events, it was also more associated in women with SPD compared with normally functioning bioprosthetic valve, and more frequent in women with left-sided compared with the right-sided. However, the women with left-sided bioprosthetic valve had less complex underlying cardiac anatomy, like simple congenital heart disease or rheumatic heart disease, compared with women with right-sided BPV, yet had worse outcomes. Why left-sided structural valve dysfunction more associated with cardiac events? Because there is limited ability to tolerate the hemodynamic changes of pregnancy in the setting of left-sided obstructive lesion. During pregnancy, there is an augmented plasma and stroke volume. With a fixed left-sided inflow and outflow obstruction, the increase of cardiac output leads to an increase in transvalvular gradient, an increase in left atrial pressure in mitral valve obstruction, and increase in left ventricular pressure in aortic valve obstruction. Furthermore, the physiological tachycardia of the pregnancy decreases the diastolic filling time. So these all are the reasons that left-sided valve dysfunction is less tolerated. However, the valve dysfunction of right-sided prosthetic valve had no significant impact on cardiac event risk, which shows that right-sided stenotic and regurgitant lesions are usually well tolerated. Discussion about the overall outcomes for young patients after the Ross operation in comparison with other aortic valve substitute has been reported. In this study, only one pregnant woman had dysfunction of the pulmonary autograft. After the Ross operation, only one pregnant woman had dysfunction of the pulmonary autograft in the aortic position, 18 years after the surgery. It is believed that the degeneration of the autograft valve is less frequent because of the living tissue and because of favorable hemodynamic status. Fetal events result. Fetal events occurred in 28% of the pregnancies, and the fetal event rate was particularly high in women with left-sided prosthetic valve with valve dysfunction. And the concept is that the lesions which are associated with limitations on cardiac output impair the growing fetus. Clinical implications. So in this we have the best choice of processes in a young woman requiring replacement of the aortic or mitral valve remains a complex decision. And valve dysfunction is more common in young pregnant women with left-sided prosthetic valve, and even early after valve replacement, and was associated with increased risk for cardiac event and fetal event. Although most maternal cardiac complications reported here were treated medically, one woman died, 2 required cardiac surgery during pregnancy, and 1 required cardiac surgery immediately after childbirth. This new information needs to be incorporated into clinical decision-making when discussing valve selection with young women of childbearing age. In addition, 20 pregnancies in women who had underwent Ross operation, only 1 had dysfunction of the autograft, suggesting that this might be a good valve choice for some women, especially at centers with expertise in this procedure. The high rates of valve dysfunction in this population of young women with prosthetic valve highlight the need of ongoing close surveillance in such women. And there should be preconception counseling. And in case of some significant valve dysfunction, prosthetic valve replacement choice must be offered. There should be frequent clinical and echocardiographic follow-up. And in addition, women should be on aspirin for the prevention of valve thrombosis. And delivery plans should be made, and it should be followed at centers with cardiac and obstetrical expertise in pregnancy and heart disease. Limitations of the study was that it was a retrospective review of a prospective cohort study. And because there was because of small number, women with tricuspid prosthetic valve were underrepresented. And more women, most women with left-sided prosthetic valve have simple congenital or acquired heart disease, and they might not necessarily be routinely cared for at specialized tertiary center. Therefore, it is possible that more pregnant women with prosthetic valve dysfunction were referred to the cardio-obstetric clinics compared with the women with normally functioning prosthetic valve. So what is the conclusion? The conclusion drawn was that the risk for adverse maternal cardiac event and fetal event was substantially increased in women with valve dysfunction of any left-sided prosthetic valve. That is 47% associated with 47% maternal cardiac events and 60% fetal events. This is a graph showing the same, that the left-sided prosthetic valve dysfunction were associated with more cardiac events and fetal events like heart failure and arrhythmia in mother, and fetal events like preterm birth and small for gestational age in the fetus. So the risk for adverse maternal cardiac event and fetal event was substantially increased in women with valve dysfunction of any left-sided bioprosthetic valve, and counseling regarding the reduced longevity of the left-sided prosthetic valve and its implication for pregnancy outcomes must be included in the discussion. Thank you.
Thank you, Dr. Apurva. You nicely presented that thing. I just want to have a thing, though the studies mainly with the cardiologists, actually they have not told anything about the rate of cesarean section, mode of delivery and all, I think, in this study. And it has not been told about, I mean, do you think that these women need subacute bacterial endocarditis prophylaxis during labor?
Yes, ma'am. Prosthetic valve comes under high-risk group for prophylaxis for infective endocarditis. So they should receive prophylaxis for infective endocarditis.
So this is mainly a bioprosthetic valve retrospective study. If you have a comparison with any study, did you go through any study comparing with the mechanical valve replacement and a bioprosthetic valve replacement? Anything else, study?
Yes, ma'am. There was a study, ROPAC, Registry of Pregnancy and Cardiac Events, in which they had compared pregnancies in women with mechanical heart valves, bioprosthetic heart valves, and women with underlying heart disease without any prosthetic heart valve. So in that study, it has been shown that like around 60% of pregnancies in mechanical heart valve were uncomplicated by any event. However, 80% of women who had bioprosthetic heart valve had uncomplicated pregnancies, and hemorrhagic complications and valve thrombosis and fetal loss, it was more associated with mechanical heart valve.
Thank you, Dr. Dr. Dasari Papa, you can tell your expert.
Yeah, it is a nice article, but we have less number of cases because of the rarity, and also the outcomes depend on the number of balls that are involved. So it is just a simple numbers to reach any meaningful conclusions. But the structural valve dysfunction, when I was reading SVD, our SVD was spontaneous vaginal delivery. As you said, the mode of delivery was not mentioned here, and they've not taken into consideration. And this structural valvular dysfunction, to be assessed, there should have been a preconceptional assessment before the pregnancy, that we have to, that is one of the limitations. So preconceptionally, they have not assessed this, so that women can be advised not to contemplate on the pregnancy. We don't know really what is their NYHA class before they contemplated on pregnancy. That would have been good if they would have included that also in this assessment.
Yes, ma'am.
Whether pregnancy, as of course, pregnancy does put a lot of strain on the heart, but whether it is going to impact the structural valvular dysfunction, I'm not very sure. But the functional capacity of the heart, as we know, it gets affected. And as the conclusion they have made, for younger women, mechanical prosthetics valves are always better than these bioprosthetic valves, because, and the only disadvantage is lifelong anticoagulation with the mechanical.
Yes.
Cardiologist was telling bioprosthetic valve costly very compared to the mechanical valves, and also.
But we see most of the women with the mechanical valves only.
Yes,
bioprosthetic, I think I've seen in my life only some 2-3 cases, but we always see mechanical.
So actually, if it is a younger age, mechanical valve they prefer, whereas an older age, above 50, they say prosthetic valve. And if there is a structural valvular dysfunction found prior to conception, they should have
We
valve
should
replacement, and
discourage.
then they can, then
Yes.
only they can plan pregnancy. That is.
Yes, ma'am.
Okay, doctor. Thank you, Dr.
Nice,
Das.
Apurva.
Thank
Very
you.
well. Both of your candidates are trained so well, I think, by Dr.
Thank
Priya
you,
or
thank you,
yourself.
Dasari.
They are
Okay.
presenting so
I
well.
should thank Dr. I should thank Priya Kanappan, the research methodology thing in Oxy, because when she told the short thing, I'm really very happy. I could select some topics.
Excellent
and make
presentation,
Thank
really.
you.
Especially Abhirami's slides were so good. Just so much impressed with her slides.
Thank you. Thank you, doctor. Thank you.
Thank you, madam. Thank you. So I'm really happy that both the presentations were very nice. So, and the discussions was so enlightening. So those were like really new topics. But like we have to anticipate these kind of topics, because we know that the longevity of the CKD patients have been increasingly improving. We all know that. And there are loads of young patients who need renal transplant. Either it is, as the sir mentioned, maybe it is some iatrogenic renal injury resulting in a renal transplant. Recently, we had a combined session by the renal transplant recipient with all the other specialties. We had a discussion, and that, as such, many patients who had preeclampsia, who have postnatally have not bothered to take care of themselves. They have not bothered for taking BP medications. They have resulted in CKD, and they have become a transplant recipient patients. So now we are coming to the very important topic, our day-to-day practice. So preeclampsia, and we all know that this Gestosis score is upcoming, and it is a really good score. So let us go ahead with the next presentation, which says about the prediction of preeclampsia by Gestosis score. So over to you, Dr. Abhirami. She's a junior resident from Apollo Hospitals, Chennai. So Dr. Abhirami, can you share your screen, please?
Yes.
Good evening, Papa ma'am.
Good evening.
Sunita, you
So
recognize
Dr.
me?
Sunita, madam. Dr. Sunita, madam will
You are
be
there for the last presentation also.
Yes, ma'am. So she will be the moderator for this session.
Yes, yes.
It is her students. So over to you.
Good evening, ma'am. I've shared the slide, ma'am.
Yes. Abhirami, can we have your video also, because I'm not able to see
Yes.
your video?
Yes, ma'am.
Lovely.
Good
Thank
evening,
you.
ma'am.
Over to you. Yes.
Ma'am, is my slides, are my slides visible?
Yes, your slides
it is
are there.
visible.
Yes.
Okay.
Go ahead.
Good evening, everybody. Today, myself, Dr. Abhirami from Apollo Hospitals. I'm presenting the journal on the topic of HTP Gestosis score and preeclampsia and its prediction of preeclampsia.
Next slide.
It's not moving, I think.
It's not. It's
What happened?
1 minute.
She can, yes.
A prediction of preeclampsia by Gestosis score. The journal was published in IOSR Journal of Dental and Medical Sciences. The citation has been given here. The authors are Dr. Adimula Majreshwari, Penumaka Rose, and Paidi Shrisha. The study place is Department of Obstetrics and Gynecology, King George Hospital, Visakhapatnam, Andhra Pradesh. And the study duration is for 18 months between June 2020 to December 2021. Introduction. Preeclampsia is one of the commonest complications of pregnancy, which is affecting almost 4.6% of pregnancies worldwide. It is one of the major complications. It is one of the major maternal as well as the perinatal complications. It causes brachioplacentae, disseminated intravascular coagulation, pulmonary edema, acute renal failure, heart rhythm variations, and also it has effects on other organs like liver, brain, as well as lung. And the perinatal complications being fetal growth retardation, preterm deliveries, and fetal death. The plethora of maternal risk factors have been established to be linked with the development of preeclampsia.
These factors have been described by individual researchers. By taking all of them into account and devising a scoring system for preeclampsia, prediction is needed, especially for countries with limited resources and lack of biomarker testing facilities. The hypertensive disorders during pregnancy includes 4 categories, which involves preeclampsia or eclampsia, gestational hypertension, chronic hypertension, and preeclampsia or eclampsia variants, which are superimposed on chronic hypertension. So quickly going on to the definition part, where the preeclampsia was defined as blood pressure elevations of systolic BP more than or equal to 140 mmHg and diastolic BP more than or equal to 90 mmHg or more on 2 occasions at least 4 hours apart after 20 weeks of gestation, coupled with proteinuria, which is 300 mg or more per 24-hour urine collection, or protein creatinine ratio of 0.3 mg per deciliter or more, and dipstick reading of more than 2+. Eclampsia being preeclampsia with seizures, and gestational hypertension is de novo hypertension, which develops after 20 weeks of gestation in the absence of features of preeclampsia. And chronic hypertension is elevation of BP before 20 weeks of gestation or which persists beyond 12 weeks postpartum. Chronic hypertension with superimposed preeclampsia is increased BP and new onset proteinuria or other end organ dysfunction in addition to pre-existing hypertension. So here is a journal which has been published in the IOSR. The objective of the study is to determine the relationship between HTP Gestosis score as well as preeclampsia. The materials and methods. The type of study, it is a prospective study, and the study place is Department of Obstetrics and Gynecology, King George Hospital, Visakhapatnam, Andhra Pradesh. Study period is June 2020 to December 2021, which was done during the COVID time. The sample size is almost 50 patients. The inclusion criteria includes patients with the age of more than 18 years and who are pregnant individuals who are booked cases, and the exclusion criteria being pregnant women with COVID-19, malignancy, liver diseases, intake of alcohol or substance abuse, or smoking. Here I've given the methodology where initially all the patients, all the antenatal patients will be taken. The detailed demographic history will be taken from all the antenatal patients who present, including the age, parity, obstetric history, menstrual cycle regularity, polycystic ovarian disease history, duration of marriage, past medical as well as surgical interventions, and previous or present medications which they are taking. Following history taking, the patient will be taken up for clinical obstetric examination, and then the patient will be evaluated based upon the weight and height, and BMI will be calculated. After that, venous blood sample of 5 ml will be collected around 11 to 18 weeks of gestation for CBC, complete blood count, thyroid profile, blood sugars, blood grouping and typing. And in this study, we have taken the blood sample for the estimation of autoantibodies, which includes anti-TPO, anti-nuclear antibody, rheumatoid factor, anti-dsDNA, SSA, and SSB antibodies for screening the autoimmune diseases, which play an important role in development of preeclampsia. Here I've given the Gestosis score. The score involves all the existing as well as the emergent risk factors for preeclampsia. A score of 1, 2, or 3 will be allotted to each risk factor as per its severity of development of preeclampsia, and a total score will be entered in the master chart for every patient. The Gestosis score will be calculated using an app, and it will be classified into mild, which has score of 1, moderate, which has score of 2, and high risk, where the score of more than or equal to 3 will be given for the prediction of preeclampsia. And the mild risk factors being age older than 35 or younger than 19 years, maternal anemia, obesity where the BMI is more than 30, primigravida, short duration of paternity, women born as small for gestational age, PCOS, interpregnancy interval of more than 5 years, and who conceived with ART, and mean arterial pressure more than 85, chronic vascular disease, and excessive weight gain during pregnancy. These are all the mild risk factors which are given the score of 1. And moderate risk factors being maternal hypothyroidism, family history of preeclampsia, GDM, multiple pregnancy, obesity where the BMI of more than 35, and hypertensive disease during previous pregnancy. These risk factors are given a score of 2, and the severe risk factors being pregestational diabetes mellitus, chronic hypertension, mental disorders such as schizophrenia, inherited or acquired thrombophilias, maternal chronic kidney disease, autoimmune diseases like SLEs, Apla syndrome, and rheumatoid arthritis, pregnancy with the artificial reproductive techniques will be given a score of 3. And coming on to the management of preeclampsia, when a pregnant woman's total score is more than or equal to 3, she'll be labeled as at risk for preeclampsia and the patient will be managed accordingly. And the treatment for preeclampsia will be started if the BP remained higher than 140/90 mm of Hg. Here in this study, the first line therapy which was mentioned was Lebitlol at dosage of 100 mg BD up to a maximum dose of 2400 mg can be given. And the second line drug being nifedipine, which is preferably an extended release combination at a dose of 10 to 30 mg, OD was prescribed as a second line drug. The result of the study is that the number of patients who were included in the study was 50, out of which the patients who scored more than 3 were 34. Out of these 34 patients, 26 patients actually developed preeclampsia, and number of patients without preeclampsia was 8. And of the remaining 16 patients who scored less than 3, out of those 16 patients, 14 patients remained without preeclampsia and 2 patients have developed preeclampsia. And comparing our study with other similar studies which has been published in other journals, here I've given the HTP Gestosis score as predictor of preeclampsia, which was published in between January 2022 to, the study was conducted between January 2022 to July 2022. Here in this study, the aim was to investigate the level of association of risk factors in HTP Gestosis score with the development of preeclampsia, as well as its predictive performance was also taken into account. The study, this is also a prospective study, but the study group here is almost 100 patients, and the study place is Government Maternity Hospital, Tirupati. The inference is that out of 100 patients, 30 patients here have got score of more than or equal to 3, and 70 patients have got score of less than 3. Here, the result is that pregnant women who got score more than 3 were prevented from preeclampsia because of early identification of preeclampsia using Gestosis score and early intervention. And another similar study which was published in Journal of Obstetrics and Gynecology of India, JOGI. Here in the study, the aim was to determine the sensitivity, specificity, positive predictive value, negative predictive value, as well as the diagnostic accuracy of HTP Gestosis score for predicting preeclampsia. The study group here was much larger, which included 534 pregnant patients who were admitted and screened, out of which 473 were finally included in the study. This is also a prospective study, which was done from a period between June 2020 to December 2021. The study place is Department of Obstetrics and Gynecology, Jammu. The inference of the study is that Gestosis score was 2 in 204 patients and 1 in 200 patients, and more than or equal to 3 for 69 patients. During the follow-up, almost 71 patients out of these 473 had actually developed preeclampsia. And other similar article is that the study of Gestosis score for HTP at 12 to 20 weeks and its evaluation for prediction of preeclampsia, which was published in International Journal of Academic Medicine and Pharmacy. Here in that, it has stated that among 200 antenatal subjects, 87 had Gestosis score of 1, 29 had a Gestosis score of 2, and 22 patients had Gestosis score of more than or equal to 3. Whereas 62 patients did not have any risk factors and they were not given any score. So subjects who had a Gestosis score of more than or equal to 3 were 22, which included, states 11% of the subjects, and out of these, 12 persons have actually developed preeclampsia. Therefore, the sensitivity of Gestosis score to predict preeclampsia was almost 50%. 12 out of 22 have actually got the preeclampsia, so it's almost 50%. It's sensitive in predicting the preeclampsia. And subjects who had Gestosis score of less than 3 were 178. Out of these 178 patients, 18 patients had developed preeclampsia. Hence, the specificity of Gestosis score is almost 96%. Positive and negative predictive values were 72% and 91% respectively. So this is the result for the JOGI study, which was published in Journal of Obstetrics and Gynecology of India. In that, among 71 women, 59 were correctly predicted by HTP Gestosis score of more than or equal to 3, while among the remaining 12 patients, 8 patients had got Gestosis score of 2 and 4 patients had Gestosis score of 1. So the sensitivity of the study was 83%, specificity was 97%, and positive predictive value was 85%, negative predictive value was 97%. So the diagnostic accuracy of the study is almost 93%. So coming on to discussion part, the study holds importance in raising the awareness for the prevalence of preeclampsia and how a simple scoring system can be able to predict the development of preeclampsia, thereby providing an opportunity for adequate management of the patients to prevent the adverse outcomes which are associated with preeclampsia. So HTP Gestosis score is a simple risk model which was devised. This provides a scoring system which is easy, accurate, and feasible, which can easily be used even by a less skilled worker like ASHA worker at ground level. It considers every relevant risk factors. The severity of each clinical risk factor's role in the onset of preeclampsia will be indicated by a score. So a comprehensive history and examination of women will yield a finer score, and the pregnant women were classified as at risk for preeclampsia and will be treated accordingly if the score is more than or equal to 3. This scoring system should be done at each visit, and if the score is more than or equal to 3, then female should be monitored vigilantly for sign and symptom of preeclampsia or eclampsia. So in our study, the prevalence of preeclampsia was 5.6%. When comparing with other studies, the prevalence was 15.01% in Georgi study for preeclampsia. As per Gestosis score, 3 categories of scoring factors exist, and studies have found a significant association of these factors in predicting the preeclampsia. So the Gestosis score raises awareness for the prevalence of preeclampsia and is a marker. So coming on to the strengths of the study, Gestosis score raises awareness for the prevalence of preeclampsia and is a novel early marker for the predictor of preeclampsia, so allowing for prompt management of the patients. It is easy to use and can be used even by less skilled workers. When resources are limited and when there is non-availability of biomarker testing, universal screening with a simple risk marker like Gestosis score can be used. It can be used for timely diagnosis and monitoring of at-risk women, and timely interventions can be made, and maternal and fetal outcomes can be better managed better. And the limitations of the study being it is a very small sample size, and the study type has been mentioned, whether it is an observational study or cross-sectional study, it has not been given. And the blood sample collection here in this study, it has been done between 11 to 18 weeks, which should have been earlier for better management. And the study might have recall bias, and study was not taken for discussion and it was not analyzed statistically. And investigative tests like autoantibody screening are costly. Thank you.
Actually, we have chosen the study. One is Gestosis score was important, and another thing, this study there was no statistical analysis at all. There was no discussion at all. Then how it was published in a journal? I really wonder. There was no statistical analysis. Only one line written. It is 3 out of these numbers, and no p-values. Nothing has been mentioned, and there is no discussion also written in the journal publication. So this type of article also can be published in a journal.
Yeah,
That is
the problem. Okay, nicely presented, Dr. Abhirami. That is why I think you made her include lots of other published studies, because this article is not proper. This is an example how a study should not be conducted.
Yes.
It may be published because the journals, you pay some money, they publish it. No, so this will not be published in a PubMed indexed journal, a very high impact journal, but just for publication's sake, PGs, NMC needs them to publish, so they have to. Yeah, this is I understood that this is one kind of that publication, like in 3 days, 5 days. You should get. This is what happens with the NMC, how they brought down the quality of the research goes like this, because when they keep such restrictions, I feel it is such a restriction. It is not possible for a PG to publish, do the study, submit, and it is not possible to publish within 6 months. No good study gets published within 6 months.
That is true. And that in each medical college with lot of PGs from where they will get the clinical material.
It's very, very difficult. Very, very difficult. They have learned the research how to do a research, how to do presentation while writing a thesis. But just publication, then only they will be sent for exam is really this what it results in. This kind of publications, no doubt about it. No doubt about it. So very nicely presented. So first thing is that a sample size. The limitation you rightly said, the sample size is not correct, calculated at all. So preeclampsia, we know overall 5 to 7%. Most of the studies say, but some parts of the world, the incidence is very high, as high as 15%.
10%.
So, but we calculate the sample size with minimum number, the lowest number, because we should include more cases to get a statistical significance. So your sample size will depend on the incidence of the preeclampsia or overall hypertension in your institute where you are studying. That is one thing you have to take past 6 months or 1 year statistics and see what is the incidence of hypertension in your institute. Then you calculate the sample size. That would be a better, because then only you can get cases. The other limitation is, Dr. Goraka had come, Gestosis in Pondicherry. We were telling that time this publication was not there. Validity of the study, validity of the parameters included. Of course, most of the parameters are also included in the RCOG guidelines, what they have taken to predict these parameters. And we have to, publish or calculate separately for each score. Even with one risk factors, we are giving prophylaxis with aspirin, isn't it? Even with one risk factors, sometimes two risk factors. Of course, more than three risk factors, it is a very, very high risk for developing preeclampsia. But even if a previous history of preeclampsia, we are giving aspirin. That is only one risk factor. So a lot of statistical differences will come with these compounders. Even with prophylaxis, how many are developing this hypertension, we have to check. Because we are not going to leave the patient with risk factor without giving any prophylaxis. Starting dose, this score has to be done when the patient comes to you in the first visit, first trimester. So maybe some people say ideally preconceptional period also.
Yes. I also feel that it has to be done preconceptionally.
Yes.
Because aspirin you can start as early as possible.
Yes.
And most of the studies, but madam, if you see most of the studies, they have done the scoring at end of the first trimester.
Yes. No, it should be the beginning. Before 12 weeks ideally, so that you can start giving it after that. So there are lots of statistical errors when we calculate the sensitivity and specificity. Any test to be more sensitive, at least more than 70%, it should be sensitive and specific. But here they say that some of the studies only 56% of sensitivity. You said some of the studies. So the study has to be conducted very well. You should use good statistical methods for each score. Score 1, what is the sensitivity? If you have score 2, what is the sensitivity, specificity, negative predictive value? For score 3, what is it? So in 3 different ways, because Gestosis has given these 3 scores, 1, 2, 3, more than 3. The risk factors, but prophylaxis is the same, calcium, aspirin, and all those things. We cannot leave these women. It is not ethical without giving prophylaxis to leave this woman, because the standard of care is that we have to give prophylaxis. That is one ethical issue to do more number of studies. Of course, it is very simple, cost effective, and nice to use it in the peripheral centers where the women don't come to us. Nice presentation. You brought out all the limitations of the study very well.
Thank you. And there are some studies also they are like including this artificial intelligence into the score and how it can predict. That
Now
is, I think,
everything
published
is
here.
there. All
Yeah.
predictive
So,
studies,
yeah.
predictive models are including AIs even for gestational diabetes. No,
Diabetes also.
include.
Yes. For ovarian cyst, like AI system is coming and incorporating in each and everything.
Yes,
So
yes.
that automatically it comes out with the score, how much is the score and how much risk is for preeclampsia. And lot of studies are also there on just they're comparing with the other predictors like uterine repulsory index
Yes,
and
with the
this
biochemical markers.
yeah, markers. They're comparing just to check the validity of the score. So
Nice.
I feel that like this journal, like particularly this topic, like this was chosen maybe to show like how like article should not be written like this.
Yes, yes.
Without any statistical analysis, without any discussion.
Yes, yes.
Thank you, madam. Thank you.
Thank you. Thank you.
Thank you, madam. Thank you.
Bringing out all the points.
Yes.
For Oxy committee, it was a real nice, useful evening. We had a good webinar. Thank you.
Thank you,
Priya,
madam.
for
It was-
coordinating.
Thank you,
with this.
Prema ma'am. Thank you,
Thank
Papa
you.
ma'am. Thank you, Priya.
Thank you
you,
very
ma'am.
much.
Thank you.
Nice seeing you all. I feel so happy today.
Thank you,
You, madam. Lovely.
Nice.
Thank you.
Nice, Priya.
Welcome,
And
Deepa,
very
madam.
well
Thank you.
coordinated.
Thank
You have
you, ma'am.
chosen good articles.
Thank you.
Thank you, ma'am. Thank you. So the
Okay.
articles are actually the experts, I mean, like the moderators have chosen for their own PGs, madam, and they really did a very good job. So wonderful presentation. All the postgraduates really did a very nice job.
Yes.
And like in detail, they understood, and definitely all the credits we want to give it to the moderator because we are behind
Yeah,
them to just
give
make
them the
sure that it's
certificate.
Yes, ma'am.
Certificate
Definitely
of
do that.
presentation.
Yes, ma'am.
Okay,
Definitely do
bye.
that.
Good night.
Thank you.
Thank
Thank
you.
you.
Bye.
Thanks
Good
a lot,
night, ma'am.
everyone. Thank you, ma'am. Thank you. Thank you.
Thank you.